See, exactly.
You are a trailblazer. I think we don't compare.
Yes, you have to be a trailblazer as a nurse.
It has to feel how we feel sometimes too.
Exactly.
We start. Yeah. Good afternoon, everybody. I'm happy all of you are here, fresh and excited on the first day of the World Health Assembly. It's a pleasure for me to welcome you in this event, Hairton Women Leadership in Gender Responsive Health. It is a pleasure. I'm Catherine Urbaiz. I'm the Executive Director of the Health Diplomacy Alliance, and I will be your moderator throughout the day. But we know we are here gathered with a majority of leaders and uprising leaders to discuss about women in global health and diplomacy. And for that, I would like to take the opportunity and give the floor to Lucia Chicote from the Permanent Mission of Spain in Geneva, and she's a human rights advisor. So welcome. You have the floor. Thank you very much.
Thank you very much, Madam Moderator and Excellencies, distinguished participants. It is my pleasure and an honor to welcome you to this event on behalf of the Permanent Mission of Spain here in Geneva. And I would like to start thanking our partners and GWL Voices for the commitment to advancing women's participation as a prerequisite for effective governance and better public policy. We gather here in the margins of the World Health Assembly at a moment when the lessons from recent global crises remain clear, that, and this is an astounding lesson, that health challenges do not respect borders, and neither can our responses. We are living in a time marked by fragmentation, disinformation, and geopolitical tensions, combined with an increasing pressure on the multilateral institutions. And defending global health means defending multilateralism itself. And this is a belief that Spain has and shares firmly, that multilateralism is the only effective way to address today's global challenges. And that is why my country advocates for a more democratic, transparent, and inclusive and equitable global health architecture. And our president has delivered this very same message a few moments ago at the plenary of the WHA. And this also comes with a clear conviction that there can be no effective global health governance without gender equality. We say this in a context of shrinking development assistance and increasing pressure on international cooperation. And for Spain, it is a bit to go against the current to defend global health, both as a universal right and also as a strategic investment in global stability, security, and social cohesion. And we do it in a moment where the consequences are real, because the budget for official aid to development has decreased, I think, an astounding figure of 30% in the last couple of years. But the commitment of Spain goes beyond the financial. And here I would like to highlight that Spain is a country that has embraced a feminist foreign policy. And to do so reflects a transformative vision of our foreign policy, a vision that is directed at addressing what are the structural inequalities through an intersectional approach, and one that seeks to reverse the distribution of power. And the latest example of this feminist foreign policy, which translates into concrete realities, is the Feminist Cooperation Strategy. One strategy that we hope to be presenting soon in Geneva, but is already starting to be deployed, and which includes 4 pillars. The first one is advancing gender equality and the full realization of the rights of women and girls. And here we give a lot of priority to the sexual and reproductive health and rights as a component of universal public health. The second pillar is ensuring women's equal participation in decision-making at all levels. This is the logo that resonates very well with the event we are having today. And the third is to mobilize adequate resources to support these goals. I mean, Spain is a middle country. We know we cannot fill the vacuum that has been left by very, very important donors, but yet our goal is clear, and we have doubled and we have increased our budget. We have increased 30% of our official aid to development. And I think our Prime Minister, our President, just announced, a commitment, financial commitment of 315 million euros for the next couple of years, 2025, 2027, to strengthen the system of global health, which we think is a sustained political message along with financial resources. And the fourth message, which I think is what also unites all of us here, is to strengthen partnerships, because without these alliances and partnerships among governments, among the private sector, among civil society, especially recognizing the role that feminist organizations are playing, we will not be able to move beyond these vertical partnerships between donor and beneficiary dynamics that really now need to be translated and transformed into horizontal and inclusive models of cooperation. And also to share with you another element, also at the diplomatic level, Spain has also appointed an ambassador at large for global health, which reflects also the conviction of Spain that health diplomacy is also and needs to play a central role in our multilateral engagement. Today's discussion, I am particularly honored and challenged to see all these insights from all paths, and also to see some young leaders that are going to engage in this conversation, because these intergenerational links to strengthen trust and in multilateralism are essential, especially in these days. And I would like to say why, for Spain to support the goals of advancing equality of representation at all sorts of decision-making levels, also at global health, is one of the elements that we value most. Because in the health sector, I think there's an evident paradox, and we will hear a lot about this. We know that 70% of the global healthcare workforce are women, but as we see that responsibilities increase, women progressively disappear from the leadership decision because of many structural barriers that need to be addressed. And one of those is also to take the unpaid care responsibilities and the gender biases, that's still there. And yet they are the front lines of all the decision-making spaces, especially in global health, as community leaders, policymakers, scientists, caregivers. And this paradox, which was very, very well exposed during the COVID pandemic, is something that needs to be reversed and needs to be taken out. Within the World Health Organization, I think Spain has also been pushing some elements to really make gender equality be inside all the program and budget. And for instance, in 2024, Spain, among other countries that shared feminist foreign policy, we helped promote the inclusion of a gender indicator in the WHO program framework for the coming years. And the collaboration with both the gender unit of the WHO and all the alliances to defend this issue was essential, especially because the challenge is increasingly complex, and we see it all across the multilateral spaces when even the use of gender in negotiations is becoming something contested. And this is why we think that advancing equal representation and parity leadership also at the global health architecture is essential to rebuild trust in multilateralism. And we have also some normative advances that have been shaping all this commitment. I think Spain is a country that has welcomed a lot the work done by the CEDAW committee with the General Recommendation number 40, which has included a guidance to build this parity at all levels, also in health, and making also a tool for requesting accountability. And looking ahead, I would like to share that Spain will be hosting the fifth conference of countries with feminist foreign policy, which feminism is supposed to be a tool that unites, not one that divides and that tries to keep countries apart, but one that seeks to address all these inequalities. And I think the discussions on equality and participation will take a fundamental place in this conference. And this is, I would like to end with my firm attitude to listen, to learn from you, and truly truly committed with the belief that this women's leadership in global health is a matter of equality, but also an investment that will make our societies healthier, our institutions stronger, and that will build in the end a more just and resilient world. Thank you.
Thank you very much, Ms. Lucia. This is quite interesting to hear, and the leadership that Spain has been doing, not only in feminist foreign policy, but also the role that Spain has been playing in these difficult times in global health, being a leader there in trying to bring voice and being a leader in terms of those geopolitical aspects that we see, and as you mentioned, in terms of ODA and how that reflects into process of negotiations and the use of gender in negotiation. This is something really interesting to highlight into the discussion. For that, I'm really pleased that this event is co-organized with all the partners organization. And for going more in details, we're going to open a panel discussion. And it's a pleasure for me to welcome the panelists, which I will be posing some questions, provoking questions. For me, it's a pleasure to welcome Raya Korczak, Executive Director for BMSC. Welcome. I also would like to welcome Kali Meriti from Young Egyptian Andola, and Pali Kirevati from the United Nations University. So, to start, I will address to you, Rayad, what are, from your human rights perspective, how can global health diplomacy better hold institutions accountable for integrating gender-responsive approach into policies and financing decisions? That is a complex question.
Thank you for that, Catherine, and a pleasure to be here and for us at the partnership to co-host this event with Global Women Leadership Voices, UNU, and others. Thank you for putting the question the way you did, Catherine, because I think it is important to name the problem we are trying to address here. And the problem that we are trying to address here, in many ways, is not a new one that we are looking at, but it is a problem that has in a way, started to manifest itself in very different ways than it has in recent past. We have often, in spaces like these, looked at our wins coming from commitments being made by governments, and commitment being made by partners, and commitments being made by philanthropies, and so on and so forth. Commitments are good and much appreciated, but implementation is more important. And often the gap that we are trying to navigate between the commitment and implementation is rapidly widening. Because often governments and partners make commitments to seek legitimacy, buy into agendas, but when it comes to the real brass tacks of it, when rubber hits the road, we are seeing that hasn't really materialized for a long time. A few years back, when I joined the partnership, I remember opening a session and my opening remarks said something to the effect that we are meeting in challenging times because the progress that we are looking across the sexual, reproductive, maternal, newborn, child health indicators has plateaued and reversing in many cases. This was just 2 years ago, by the way. And today, what we are talking about is a compounding of that problem. And the compounding of that problem is important to just unpack a little bit. So, as I said, we name the problem we are trying to address. What has happened in the last 2 years, particularly, one is the rapid increase of multiple intersecting crises that are taking place. According to the World Health Organization itself, today, the bulk of mortality that we are talking about in relation to maternal mortality is coming from crisis-affected countries, 63%, according to estimates released about 2 months ago. That's an important marker. And if you look at that with a little bit more complexity and you see what is happening in terms of rapid displacement and climate-related stress, we have a compounding of crises that is happening, populations being often displaced and often for not just an acute period of emergency, for a protracted period of emergency as well. The second is the funding crisis, and that crisis cannot be sugar-coated in any way. What has happened in the last year has been devastating, and what is also devastating is the speed at which it has happened. We at the partnership conducted a survey towards the end of last year, and a headline that still remains with me, and this was October 2025. We are in May 2026, so the situation has changed even more. In October 2025, what we found, about 37% partners had dramatically downsized operations related to sexual reproductive health, gender equality, and about 20% had shut down operations altogether. These are PMNCH partners that we work with. We work with 1,500 partners across 130 countries around the world, and the respondents included 20 country respondents. It was a straw poll, but this is an indicative of what we are dealing with, and specifically the programs that were getting affected related to adolescent sexual reproductive health and rights, programs related to gender equality, and those related to specifically child and newborn health related issues. Now, colleagues, with the expansion of global gag rule that took place in January this year, this situation is even more bleak and complex, because what it is now impacting is not just, as people would understood previously, family planning related funding in the historical past, but it is now impacted in terms of United States, all non-military funding. So that's about $30 billion that we are talking about. And it has also been compounded with what's happened in terms of European funding of these issues. So the impact of all this that I'm saying in the real life terms in clinics, in family planning centers, in maternal health spaces, means that women are being denied life-saving care that they so require. So we are already, as of December last year, according to the IHME data, we know that under 5 mortality of children, first time in decades, is actually increasing now, not decreasing anymore. And mother-to-child transmission of HIV is on an increase as well. All that being said, so you have a rapid deterioration of policy, funding, and now increasingly, as we enter into the rooms of the World Health Assembly, we are now confronted with another challenge, which is that related to women, children, adolescent, SRH issues being completely left out of the global health architecture conversation. Helen, who will be with us soon, and I wrote a paper a couple of days ago, which talked about the need to center women, children, adolescents' health and sexual reproductive health and rights issues in global health architecture reform. I would bet you that you cannot find even the words in the conversations that are happening right now, and that means what is not referenced is not accounted, it's not done, and that is where I think we are now at this present moment, is that of deprioritization and indeed invisibilization. Now, quickly turning to the next part of the problem, the mechanisms that are meant to hold us to account, hold the multilateral system to account, hold governments to account, hold other actors to account, are simply not working. Because if they were working, we will not be having this conversation to begin with. So UN treaty monitoring bodies, human rights-related mechanisms are practically devoid of any funding and mechanics to be operating in an independent manner. We today have another challenge, that much of our human rights architecture is hinged on state-centeredness. State as the major duty bearer and state as the implementer. State is not the biggest implementer today. It's the private sector. It's the powerful private actors which are not even there in the conversations. They are seen as implementers, but they are not seen as accountable. Our mechanisms actually do fall very short in terms of what we are doing. And the third part is the shrinking civic space. What is happening in terms of draconian legislations being implemented in countries which restrict the civic space means that that basic semblance of accountability that we are talking about is missing. So what do we do? And what is the role of diplomacy in addressing what we are trying to do, both at the global level, but at other levels as well? And colleagues, I use the term diplomacy in a bit more broader sense, because a few things that stand out, at least based on the analysis and the work that we do focusing on women, children, adolescents' health and sexual reproductive rights, is we do need to have a more complex understanding of the geopolitics that we are confronted with. The geopolitics is one that is manifesting itself in different ways in the multilateral system. So we do need to have a more nuanced, a more granular, and probably a more multipolar understanding of what we are talking about. And therefore, regional, sub-regional alliances, mechanisms are likely to provide much better forums and advantage for us to advance the issues that we are doing. Diplomacy in those forums is still winning. We are getting, if you look at what's happening in terms of conversation with the implementation of Maputo Protocol, Africa Union, this January at the summit appointed a new champion on reproductive maternal newborn child health. What's happening with SADC in terms of SRHR issues. It's very promising. I'm not sugarcoating it. There are challenges, but there are green thoughts appearing which we need to work with as partners working in this space. South-South. Learning and collaboration and diplomacy is critical. We at the partnership have the huge honor that we work with the presidency of South Africa for the Global Leaders Network, the first of its kind Global South, heads of state level mechanism working on women, children's and adolescents' health. And a huge applaud to Spain today to join Prime Minister Pedro Sanchez joining the Global Leaders Network. And there's a beautiful op-ed by him and President Ramaphosa in El Mundo and Al Jazeera in case you're interested. But that's what is important, is Global South leading from the front, Global South claiming the ownership of these issues from the front, and Global North working with Global South to make that happen. The other thing that we are finding extremely important is to actually look at parallel institutional tracks through which we can actually still advance these discussions in spite of the geopolitical deadlocks that we are confronted with. And these parallel tracks are within the system. Universal Periodic Review, for instance, which a mechanism which many in the room may not have been familiar with or engaged with, provides us with just, a peer-to-peer accountability mechanism that can be very powerful in the context we are talking about. And this is where bringing health and human rights mechanisms together is so much more important and powerful. Strategic use of spaces such as the Group of 20, BRICS, G7, and others, barring the deadlock this year maybe, but importantly, in the South African G20, the kind of issues that we were able to bring in were phenomenal. It was the first time ever in a G20 meeting, we were actually able to convene a ministerial on women, children, and adolescents' health, reflecting on issues in terms of laws and policy related to SRHR. This can happen. We need to work with the mechanisms, and the political declaration from G7 France this year makes an explicit reference to SRHR in context of global health architecture. A big win, which we cannot undermine in the kind of work we are doing. My final couple of points that I do want to say and end with, the first is building unlikely coalitions. We cannot do this alone. And the sooner we realize this, the better off we are in terms of finding ways to address the complexity of challenges that we are working with. The alliances that we will have to make are going to be unlikely, but are important, and they are going to be uncomfortable and uneasy in many ways. How do we reach out and work with the actors that we have not worked before? Roughly speaking, between 20 to 70% delivery of services related to SRM-NCH in certain settings actually happen by faith-based organizations. How do we work with FBOs in a manner that is on our terms, but also respectful of the complexity of value structures that these institutions do so manifest? And the final point I do want to make is investing in civil society organizations, investing in CSOs, in feminist groups, in grassroots organizations and coalition is the safest way for us to build a culture of diplomacy, but that also of accountability. Thank you.
Thank you very much, Shayad. I cannot summarize what you say. I tried to take notes, but it's super interesting to look how utilizing health diplomacy is an instrument to advance those areas where you're working on, and to highlight as we are sitting right now within WHO, that these discussions are not being put out in terms of the reform that we see and the architecture of global health. So that is something meaningful to look into. Dr. Falacci, I would like to know, from your perspective as director of the United Nations University and Institute for Global Health, how do you see, from the evidence and research perspective, how do you see a more effective influence in diplomacy in order to ensure that these gender-responsive health policies are being implemented?
So thank you very much for that question, and it's an absolute pleasure to be here and to speaking to all of you. I think that the evidence and the research that organizations like ours and others create and represent and synthesize and bring into policy spaces, I see it obviously as foundational to many of the processes, diplomatic processes that are happening in the global health space, but also some of the nuanced spaces that happen because we all know that health, the determinants of health are sitting outside of the health sector as well. And I think without the evidence and the research that organizations like ours present, health diplomacy will be blind, deaf, and obviously captive to the loudest noises in the room. So I think that is a space that we guard very, very preciously. And this is obviously relevant most in when interests differ. So in spaces where most of the diplomacy is consensus-driven, evidence plays a very important role in kind of helping us navigate those conversations, and of course to shape the narratives, to bring the credibility to the diplomatic discussions and also the outcomes of the diplomatic processes that we see in global health and outside. I think both the previous speakers have alluded to the fact that we are navigating increasingly uncertainty in every field that we work in. And I think evidence does help us navigate that uncertainty that we are looking at with neutrally and of course efficiently, because it's hard to defy evidence, but of course there are other things that we are challenges that we are facing. Of course, we live in an era of dis and misinformation, so counter narratives are quite important in kind of helping us bring to center the discourses that are kind of moving in directions not preferred by science. And of course, as Rajat said, IIGH and many other organizations, research organizations, do champion the leadership and the voices, the representative voices from the global south. So this is an absolute priority for us, when we are trying to balance the discourses that are happening in different global health discussions. So I would say that there are three important areas or shifts that would be necessary for organizations like ours to bring the evidence that is relevant, to influence the diplomatic processes that are happening, and to, of course, effectively do so. The first thing I would say is to stop treating diplomats as the end user of evidence. So one of our efforts is to treat them as one of the very many nodes that we work with within a system. So instead of trying to persuade them with better data or making demands on improved data on them, it's about educating them. It's about, and I deliberately use the word educating them, because they are not coming from a place of not wanting to know, but they are coming from a place of not knowing simply because they've not been exposed to some of the discussions that we navigate in the global health spaces. So bringing them on board, enabling them with the ammunition of information, knowledge, and also transferable, right? Because they do navigate multiple sectors. So making sure that they are able to navigate the health sector as well as the sectors that they are navigating in their spaces is quite important. And really equipping them to champion the issues that we are doing, and not just at the global level, but as Rajat said, also at the regional level and the subnational levels, because most of the implementation happens at that level. So making them allies in kind of, driving these ambitions that we have. The second approach, I would say, is to move from problem framing to solution forcing evidence. So, the time is now, and in different areas of global health, we are navigating shifts, not just in the geopolitics of it, the finance of it, but also the regression that we are seeing in many of the progress that has happened in the health sector. So all of this does require us to recalibrate and course correct some of the approaches that we have taken for how we are addressing global public health. So it does require us to, really looking at what are the new kind of approaches that are going to be needed to find the solutions that are going to resonate and scale and timeliness. I think this applies a lot. Catch up is one thing, whether it's because of the economic thing, whether it was the COVID, backsliding that we had, or the geopolitical changes that are backsliding many of them. And here, of course, we are talking about women and children's rights, but that applies to all of the global health issues. And it's not enough to offer the solutions, because there is evidence, enough evidence, I would say, and of course, evidence improves by time as new knowledge becomes available to us, and also the focus shifts on more indigenous knowledge systems that are coming into mainstream, in many of the approaches that are being taken, simply because it resonates better with populations and systems. But for diplomats, I think it's also important to identify the leverage points. It's not enough to know solutions. It's to equip them with where are their leverage points to act, so that then they can demonstrate the impacts that they will from their positioning point. And then shortening the feedback loops. So if implementation failures have to be brought to their attention in a timely manner, that does equip them to then, if they are champions on our side as well, then that helps them to recalibrate, that helps us to recalibrate some of the discussions that we are having. Most of the implementation from policy formulation does fail, I think, because of many areas, but three main ones. First is because the evidence is not politically salient, or some of the questions that researchers are answering are not exactly speaking to the needs of the diplomats or the decision makers that are happening. So correcting that. Ignoring the power dynamics is something that has been recognized increasingly, and that is one of the things that if you don't address that, no amount of research, no amount of solutions, no amount of financing is going to bring you to the level where you would want to come to. And then, of course, again, as Rajat said, the lack or the suboptimal functioning of the accountability frameworks or mechanisms that are available to us today. And often looking at policy adoption as the end point. So having a resolution there is not enough, or having a policy, kind of formulated in its best format is again not enough. So not seeing that as an end point, but rather looking at it. And I'm not saying anything new, but it's just that repeating this enough number of times and then having the approaches in place so that both the diplomats and scientists and practitioners can navigate this space with ease and move fluidly between the three, because increasingly we are playing these roles, in quite complementary ways as well. So my third and final shift that I would say is to move from negotiation diplomacy to implementation diplomacy. And this is because the people who are negotiating policies are not the same people who are implementing. So it requires a very different set of actors, civil society organizations, subnational, regional organizations, which are at the forefront of this implementation. So equipping them with, the evidence that you need is also, and of course, working outside the health sector. And we've recognized this increasingly historically, but probably have not acted as much as we should have and could have, but really prioritizing the systems approaches to do that. And then, of course, vague commitments are not enough. So having binding implementation roadmaps, which are then, robustly supported by transparent monitoring and evaluation frameworks, which hold ourselves accountable, but also equip us in kind of, holding the mirror to the people who are, should be held accountable, whether it's the new actors that are occupying spaces traditionally held by states as well. And I'll end with saying one unique position that UNUIIGH occupies is that sitting inside the UN system as the academic arm, maintaining that neutrality and navigating with other sister UN organizations the power of evidence and bringing that into the diplomatic spaces, I think it's a position of privilege. And I look forward to kind of, delivering to the best that we can. Thank you.
Thank you very much to bring that science, diplomacy, evidence, and how to influence diplomacy and try to lead to this implementation diplomacy. Moving forward, I would like to pass to Merete Khalil. You are the founder of your Egyptian doula, and you are a multilingual health system researcher. You are passionate about sexual reproductive health and rights, and you are an advocate. Let's position ourselves as a young women in global health, what are the barriers that you constantly have to face in order to trying to engage in global health diplomacy? And also, what are the meaningful intergenerational leaderships should look like in order for you to be part of that scenarios?
Yeah. Thank you so much, Catherine. And indeed, colleagues, it's an honor to join this conversation today on women's leadership and diplomacy for gender-responsive health systems. So I would be remiss not to mention that I definitely do not speak on behalf of the 50% of the world's population that are women, the 52% that are young people, and the 80+% of the female health workforce. I just offer one perspective from indeed someone who wears several hats as co-chair for the thematic working group on health systems and gender, as the founder of the Egyptian chapter in my home country of the Women in Global Health movement that's really pushing for women's leadership in health systems. As a founder for an advocacy organization, the grassroots level, I'm happy to hear the investment in young feminist grassroots organizations to really promote respectful maternity care within my home country. And now currently as the PUSH campaign lead, working with the International Confederation of Midwives, leading a global movement that's putting women at the center of health systems. So indeed, a humble lens into this. As a young woman working in the global health space, I am very privileged to wear two different hats, two different worlds and perspectives. One where I work and engage at the community level, where women and young people are fighting for our rights, are fighting for dignity, and are fighting for survival, now more than ever as framed by this intervention. And privileged to have access to some of these health diplomacy spaces where decisions are made about our life and are negotiated about our rights, with very few of us represented in the room to contribute to these negotiations and discussions. So indeed, what strikes me the most about this paradox is that the women who are most affected by the global health policies that are being discussed in this forum, the World Health Assembly, are still, unfortunately, not equitably represented in the global bodies that are making these decisions. In global health diplomacy, we speak about the principles of equity and inclusion, yet the barriers to that being operationalized are very real. Catherine, you asked me to speak about barriers, and I can list many. So I will only speak about three in the interest of time. I want to focus on three barriers today that are limiting young women, especially within the space. The first is access, the second credibility, and the third is unpaid labor. So let me start with access. In case you have not noticed, these wonderful spaces that we are occupying this week are still quite dominated by elite institutions, powerful passports, established networks of dignitaries, diplomats, institutions that have been in the space for a very long time, and financial privilege. For many, many young women, especially those of us from the global south, entering some of these rooms where the negotiations, where the discussions, where the decisions are made is quite literally impossible. Visas are denied, funding is unavailable, opportunities are limited. So even when we are present, our participation does not always mean influence. I think, unfortunately, many, many young women continue to face this tokenization. We are invited to share our perspectives, but we are not invited to shape agendas, to negotiate priorities, nor to make decisions. And here, there's a very big difference between visibility and power. You asked me to speak about intergenerational leadership, and I will touch on this point about power. So indeed, when we look at this visibility and power paradox, this imbalance becomes very, very striking when we look again at who's in the room, who is not, who is speaking, who's making decisions about the global majority that is not represented in this room, be it young people or women. Neither group is meaningfully reflected or represented in global health leadership, nor in the decision-making spaces here. The second barrier I want to touch on is credibility. Expertise in these spaces is too often associated with sex, predominantly men, with age, with hierarchy, and with institutional status. Who you are is very much your title, your country, your organization. Nevertheless, there are many brilliant young women who are here. Our voices, unfortunately, are often interrupted, ignored, dismissed until some brilliant older man says exactly what we just said. I hear the laughter because many of you have been in this space too. So indeed, youth engagement cannot be treated as a communication exercise, a programmatic checkbox. Oh, we have one young person on the panel, so we did it. That is not. You are the host. But no, it's an honor to be here indeed. But I think indeed the more pressing challenge here is when we look at global health governance and we see this exclusion very manifest. We're excluding those who are closest to the realities where these policies are manifest. How is it that we can continue to exclude young people, women, frontline healthcare workers, particularly midwives, their realities and their lived experiences from the decision-making tables? This disconnect is very dangerous. If we are serious about building equitable health systems, then we must include the voices of health workers, particularly midwives, one of the most feminized health professions, in diplomacy and decision-making spaces. Midwives, when we talk about the SRHR agenda, we know that midwives are able to deliver upward of 90% of essential sexual, reproductive, maternal, neonatal, adolescent, child health. 90%, people. Yet they comprise 10% of the global health workforce, and they are not adequately represented in the decision-making tables. We know firsthand how these policies that are not reflected in the lived realities of people will continue to fail, and we've seen that over and over. Despite their expertise, midwife, young people, and women continue to be underrepresented from global health policy. Now I want to come to the third barrier, which is all about unpaid labor. For many, many young women, there is an expectation around our tone and our leadership style. We are expected to be confident, but not too confident or ambitious. We are expected to be passionate, but not too emotional. This ping-ponging is difficult to imagine, to balance, especially when you are navigating a new space that is not built for you. Many young women spend a lot of energy navigating perceptions, workplace harassment, and structural barriers before we can even get into the room. And of course, once we are here, we have the challenge of making sure that our voices are actually heard and not echoed by someone else with a mic. But moving on. Indeed, when we look at unpaid labor, we look at the fellowships, the volunteer work, the advisory groups, the advocacy campaigns and consultations that frequently rely on the invisible labor of young women in the space, who are expected to contribute their expertise, their lived experience, their emotional energy, their sleep, their time without fair compensation or institutional support. All of this is not even mentioning the massive gender pay gap that we are continuing to fight for in many, many of our countries, where we can just be equally compensated, just the same as our male counterparts. So here we are having these conversations about equity, about inclusion. Yet, the global health diplomacy space is not designed for us. We are trying to transform it. We are trying to crack it. And this is exactly why we come to this second part of your question. This is exactly why we need meaningful intergenerational leadership. Not as a slogan, but as a genuine redistribution of power, of trust and opportunity. And I extremely appreciate the intervention by Honorable Lucia from Spain, touching about this action. It takes action. It takes a redistribution of power. Meaningful intergenerational leadership is not about older leaders or more seasoned people in this space stepping aside. It's not about romanticizing young people. It is about moving beyond mentorship alone and sponsorship towards shared decision-making. It is actually about sharing power. It is about sharing opportunities. We, young women, we do not need just your advice. Yes, we welcome it. But we need opportunities. We need leaders who will nominate us for positions of power, who will include us in the negotiations, who will include us in delegations, who will share authorship with us, who will open doors that we will not have access to otherwise. We need to shift from consultation, making sure there's one young person on a panel, to actually co-creating some of these policies and strategies. Young women and frontline workers should not just be invited to react to decisions and policies, but rather we need to be involved in the processes that are shaping them. From the beginning, in the agenda setting, in the policy design, in the governance, and in the accountability structures. And most importantly, we need to start shifting the narrative about expertise. Too often, health diplomacy continues to value institutional credentials while dismissing the expertise of and the lived experiences of the realities of those whose health policies we are shaping. Lived experience is expertise. Frontline healthcare workers' experience is expertise. Midwifery is expertise. Community leadership and advocacy and activism is expertise. If we're really keen on meaningful intergenerational leadership, then this needs to stop. We need to stop asking young women and midwives, frontline healthcare workers, to earn space in systems that are not built for us, and start building the systems together with us, co-creating with us. As you see, and there are many others around the room, young women are already leading. We are leading movements, we're leading research, advocacy, campaigns, humanitarian responses, policy interventions and innovations in our countries. The question is not whether young women are ready to lead. The question is whether institutions, and within this context of the global health architecture, is truly ready to share power and make space at the decision-making table for the meaningful integration and engagement of young leaders, particularly young women leaders. Meaningful intergenerational leadership requires a change in culture. It requires a transformation. It means creating environments where questioning power is welcomed rather than punished. And for the activists in the room, I know you feel this burn. Young women can often, when we disagree and when we challenge power and privilege, will be labeled as difficult, will be labeled as a problem, we will be dismissed. What we want to see is leadership that is collaborative rather than tokenistic or extractive. We want to see health systems where well-being of those providing the care as well those seeking it is valued, not just how productive the health system is. And indeed, we need to really ensure that it's not just the representation. We cannot continue to celebrate having young women in rooms while we maintain the systems that silence our voices when we arrive. So I challenge all of you to reimagine with me. Let's reimagine a model of diplomacy where leadership is not concentrated with a few, but shared democratically and equitably in a transformational way that is actually equitable and inclusive. Can we rebuild the global health infrastructure where young women are not just seen as future leaders, but are recognized as the leaders that we are now? Can we move beyond this tokenistic approach to true partnership across generations? So I leave you with this question. Now that we are imagining it, we are living in a reality where it's real. Can we do it? Are we really ready to start challenging institutions to share power and to meaningfully engage those whose lived realities are actually, should be, shaping global health policies? Thank you.
I think I should have not asked you a question because you brought it back to me. You brought it back to me, but I think I will bring it to the public to answer that question. Really well thought, and I stay with the system, not the room. That's what we have to change. It is amazing what we have heard in this panel in terms of prioritization, how the work in terms of gender inclusiveness is not even considered in certain geopolitical discussions, in certain forums. And now as we are here in WHA, is it part of the reform process? How women are involved into all this process, how young women are part of it, to shape it, to shape the system, how evidence is necessary. I'm getting myself close. How evidence is necessary to not only influence, but also to collaborate with diplomats to be able into this diplomacy implementation process as well. So I think we have a lot of topics here to be able to open the floor and then see the reactions of those in the public, because I think there is a lot of materials there to discuss. And I take this opportunity to open the floor and to answer her question, because I'm not going to answer it. So the floor is yours. I see already. Yes, please identify yourself, please, and if you are addressing your question to anybody in specific.
Yes,
Yeah.
thank you so much. I'm Karen Nilsson. I'm the Executive Director of She Decides. And congratulations, this was such an excellent panel and really clear insights and recommendations and analysis. My question is to Honourable Lucia, and also linked to your excellent points, Merete, when it comes to youth leadership, and thank you for your youth leadership and for the inspiration and for your expertise. And congratulations to the government of Spain for providing the political leadership in really walking the talk when it comes to delivering on gender-responsive political diplomacy and moving forward when we see a lot of governments also moving slightly backwards, including when it comes to investments in ODA and global partnership in advancing gender equality. We see, of course, the very strong pushback on gender equality, on the anti-gender, anti-rights movement pushing back. And, of course, Rajat, you pointed to the multi-crisis, of course, in terms of all the challenges that the global health financing structure is going through right now. Sorry, a long context setting, but it's such an important momentum for the Feminist Foreign Policy Forum for leaders to come together, also with youth leaders, and the trailblazers in standing up for the right to decide over your own body, life, and future, where we see sexual and reproductive health and rights and investment in it to sustain global health and advancement in gender equality. As you really clearly pointed out, it will be impossible to achieve gender equality without sexual and reproductive health and rights, and without gender equality within global health, we will not reach the goal. So now we have 4 years left to the SDG is going to be completed, and looking into the situation when it comes to gender equality and the role of feminist foreign policy. So with the governments who've been pushing forward, that has also come with a political accountability. You know, when you have clarity on it, we need to transform. It needs to be transformative. You have to have a gender-responsive budgeting to transform the political commitments. My question is, what are your expectations and hopes, and in what way do you see help is needed in terms of other governments supporting moving forward and not backwards when it comes to gender-responsive budgeting? We have many governments who share the equal focus on resources, rights, and representation. Merete, with your reimagination, is the fourth R, I think, in reimagining a feminist future where we have that interconnected way of working across generations and sectors. But it's concerning, of course, the political landscape when it comes to political diplomacy with the political pushback. So I'm curious to hear your vision. What are you hoping to see getting out of this really important moment of feminist foreign policy and political leaders coming together with experts in terms of advancing global health through diplomacy? And you play such a huge role, and you're such an inspiration. So we're looking up to you. We're following your political leadership, and we hope you will also inspire other global leaders. But we know a lot of gaps missing in terms of that political voice for gender equality and for progressing rights and for connecting in a feminist way across sectors and generations. So thank you so much both. Thanks.
No, thank you so much for that very challenging question. Well, I've been working here in the multilateral diplomacy for the past 5 years, and at some moments, we thought that it takes a lot of energy, and that feeling that I conveyed, that was a sense of navigating a bit against the current. But what I can tell you that inspires us hope and how to address feminist foreign policies is first to expand the concept and stop using feminism as an ideological word that really raises the alarms, because it is something that is understood as something too progressive that only a very selected club of countries can embrace, but to really a bit unpack the concept of what feminism means, and which is to connect it with the transformation and to speak about all the audiences. And then when you start speaking about feminism, you start speaking about maternal health, about access to education with equality, equality, about not being left out of school because you are pregnant at state, or we were listening here about speaking about how like all the young voices want to have a space at the table. So I think that this is something that that the feminist foreign policy, at least how we try to implement it, is trying to be focused instead of focusing on we are very, very small group of countries that share a certain vision, but try to embrace the difference. And in this respect, I think the angle and the community of countries that are placed geographically in the north, but which share the commitment and the goals to transform these realities with other countries in the south, and to expand that alliance with including civil society, the UN agencies that are working in gender equality, like UN Women, UNFPA. All this community is embracing and seeing something that really increases the hope in the things that can be transformed, and also to try to something that I think has been also very positive and is really it's very badly needed, is to start use like gender equality as not an ideological question, but also as an investment. And why it is so that when women are included, all the societies are developed and the societies prosper and build. And that's why I think also Spain has been very, very able to connect all the priority given to the transformation of questions dealing with the financial architecture and those inequalities that really need to be reversed, with bringing gender equality in those conversations. And I think that is hopeful in terms of aspiring that things can be changed and can be transformed, and why gender equality can have a place at those discussions.
Thank you very much. Any other reactions, thoughts? Yes, please, over there.
Hi there, my name's Regina. I'm representing Sigma Theta Tau. Sorry, was everybody else using the mic? Should I not use the mic? Okay, yeah. On behalf of Sigma Theta Tau International Honor Society of Nursing, very long name, so Sigma Nursing for short, we know that women comprise almost 70% of healthcare workers globally, and nearly 90% of that is represented by midwives and nurses. However, it's estimated that only 20 to 25% of leadership is being held by women. And so, as many of you had said, that lived experiences on the ground is crucial as expertise. And we know that for many of patients, nurses and midwives are the first point of contact and sometimes the only healthcare providers that they see. And so we know that using our power, using this evidence and using this data, it is so crucial to be able to connect gender equality with a lens of leadership, of advancing health equity for all. So my question is, how can we collaborate across sectors to ensure adequate investments into gender equality and leadership for stronger health systems? Because we know that when midwives and nurses are constantly being attacked, we don't have adequate remuneration, we don't have adequate representation at the decision-making table, despite making up so much, the majority of the global healthcare workforce, 60 to 70%. So how can we, utilizing this data, advance both gender equality and also to make sure that all patients are safe when we know that there's adequate health system strengthening that includes women and nurses and midwives at the table? Thank you.
I also, I don't know if there's any reaction to that, but I also want to acknowledge women who are working in parliamentarians, and we have somebody from the Tanzanian parliamentarian, Dr. Hamid, who's a leader in terms of women leaderships at the parliamentarian level. So welcome, pleasure. Yeah, pleasure. Yes, please.
This one here? Okay. Thank you for that very inspiring talk. And in fact, after you raised the question, I didn't really have a question, but I'll still put it out there. I work for Gavi, and one of the things that I do in Gavi, which is not my day job, one of the off jobs that I do, is I lead an organization called the Women at Gavi. We're an affinity group, we're an intersectional group, and one of our objectives is to make sure that the workplace is a happy workplace where women actually find self-worth and they see a career path ahead of them, and there's no barrier for them to access anything that they want to do. And unfortunately, with everything behind us, it's been a bit of an uphill climb. But the question that I'm putting to you, all of you, is possibly rhetorical. I mean, we've had, I was looking at all these statistics. We get given these statistics very often. And I was thinking back to how there are certain organizations that have always historically had women executive directors. We've got UNICEF, historically always led by a woman. We've had UNIFEM, we've UN Women, and so on. And of course, we're very proud that we've got the first ever CEO to lead our organization, and it's still a bit of a challenge to ensure that we've got enough women, we've got intersectional representation. My question is, how do we ensure that women leaders stay true to what we expect them to stay true to once they're in power? How do we do it? Because we've actually lost a lot of time. Thank you.
Any reactions?
I'm certainly not the right one to start on response for that one, but I did have a couple of thoughts on the previous questions, but I'm certainly not ducking the question that the last speaker asked, and I think that is an important one, and I think that kind of goes back to what Merit was saying, the challenges, the burnout, the attacks, the ridicule often that women in those leadership roles often face, and I've had the joy throughout my career to be led by women bosses, and I have had one of them sitting right next to me and another one down the table. And I think there is a remarkableness to them as they stand tall, and we travel on their coattails, as one would say, but it comes with a cost, and that cost is often not accounted for. And several of those things have already been said by Merit, but I think there is one that often I've seen some of those women leaders from afar. It's just the quiet pain that often some of them have to go through because of the kind of attacks that come their way, whether it is sometimes on the narrative or the appearance or the thing. And I'm sure, people of other genders in their role don't face the same. And then they also have to carry the job that they've been hired to do. And one small mistake, they are often held to a very different standard than anybody of another gender would often be. And it kind of, the couple of things I wanted to say, I very much agree with the colleague from the Sigma Nursing Association, the importance of interprofessional collaboration and investing in these issues, and the sort of intentionality that is required is often very much missing, and we're trying to do that better, but I don't think we are anywhere close to what is required in those spaces. And I think that's important, and we are, the partnership that I work for is trying to work with the professional associations and with research institutions to bring these conversations more closer together, but not just at the federative level at the headquarters, but at the national levels as well. But I did wanted to go back to Karen's point as well, and as you were speaking, I think one of the things that I was very stuck with, and which is important to at least acknowledge what is happening, and Judith Butler rightly talks about who's afraid of gender and why. And I think that phantasm, as she calls it, is important to take a note of, because I think what is happening with the attacks on gender ideology, the work on gender, the work on SRHR, is requiring a deeper interrogation, because it is being scapegoated for larger ploys of, seizing human rights, seizing, the kind of democratic values and authoritarianism. And how do we address that? And I think what is happening as a consequence also, especially within the social media space, the whole manosphere conversations, and we don't have conversations as often about positive notions of masculinity and gender norms that need to be brought into these conversations, because I'm sorry, but between you and I, we've been doing this for a while. We've got nobody in the room. And I think this is a challenge that one cannot just, airbrush out of it, because I think if you look at the spaces and how, going to Merit's point, how they are being occupied, I don't think it is just by chance that it is happening. There is a deliberate intent to occupy those spaces. Thank you.
You go ahead, yeah. Just. Yeah.
I can add a few thoughts to Rajat. I think that was brilliant indeed. But I think to your point that, health systems, whether at a facility level, whether at a national level, whether an INGO, we know that health systems, regardless of entity, right, or size, are not immune to gender inequalities, right? We know that patriarchy does seep into governance. And I think at the core of this conversation, this is actually what we're looking to challenge, right? Indeed, the objective of our conversation today is shifting towards gender responsive global health, but really what we should be aspiring towards is gender transformative.
Yeah.
And indeed, this is a difficult conversation to be having where it feels like we are in an echo chamber among allies and peers who agree with the mandate, especially in the face of opposition. So I think with that, I want to also share a resource that actually was just launched 2 weeks back at the Women Deliver conference that I think for many in this room could be a very useful asset, especially for those in advocacy and especially for those who are really looking to tackle this issue of the gender inequalities that manifest for both the health system users and those providing care, majority women in the health sector, which is the Feminist Health Systems Charter. So I encourage all of you to download it, look it up. One more time for those nodding and asking, the Feminist Health Systems Charter. So this is a co-created advocacy tool that comprises of 12 principles. And it was difficult to get it down to 12 principles, as you can imagine. Many people, many researchers, advocates had lots of insights into this. But what it looks at is 12 principles that outline what feminist health systems should aspire towards. And they're corresponding, looking at all, as extensive as possible, different human rights charters, principles, guidelines that are really looking to hold states accountable to protect, respect, and fulfill the right to health as an essential duty bearer. So indeed, we invite all of you to use this tool. For every principle, there is a corresponding list of human rights obligations that states have already committed to, that it is their obligation to do that. And indeed, right now, we're seeing a breakdown of this accountability mechanism and a need to say member states have already committed to deliver, for example, on the right to health. This should not be controversial. But now, apparently, this is. So these are the human rights documents. This is intended to be used as an advocacy and accountability tool that is grounded in human rights, in gender justice, and in public and community accountability to hold states and governments and health systems accountable. So indeed, we encourage you all to use it, critique it, edit it. This is a community-developed, co-created tool that really is intended to help move the needle on some of these aspects. Thank you.
Thank you. I think I will take the last question, yes, if it can be combined, both, because then we had, go ahead. I will take it together.
Maybe yours, I don't know. I don't want to take anyone's question space. Okay. Hi, my name is Stella. I'm a young doctor and a peace and health activist. And I'm still making this a little bit on the spot because I'm always filled with rage and inspiration. I never really know which one to go for in my first feelings. And yeah, I've had the chance to speak I'm here on behalf of IPPNW, Doctors in Social Responsibilities, but also young doctor training, and I've often been invited to youth forums and the checklist youth activist on the table, so I can very much relate to that, for youth expertise, which always surprises me because I'm never invited for like medical expertise, but I'm not a socialist, I'm not a teacher, I've never worked with youth, you know, it's like, there are a lot of people who are better equipped in that than this, and I even fear sometimes describing myself as an activist because I know as a young woman on a table that will stick, and not the one that I'm a doctor as well. And I often hear the phrase, well, we have to educate the leaders of tomorrow. And I'm like, but can we wait like 30 more years until this is going to happen? And so my question would be, where do you see the kind of the room to educate current leaders holding these positions at the tables? Because, I mean, I feel like our spectrum of the table knows kind of where to enter, but then as you talked about opportunities, it's really hard to reach there. So like what maybe arenas do you play at the moment where to have these conversations with current people in power? And something that struck me along the presentations is that we haven't talked about the fatigue it also creates among young women and leaders. And you talked about the frustration of it and over again. And a lot of my friends just quit because they're like, I just don't want to do this for a lot of time. And like, how do we stress the urgency of it without, I don't know. There's a lot of thoughts about it. But where do you see the arena for this happening now? My question.
I would take the together, so yes.
Can I still ask?
Yeah, go ahead.
Okay, I'll try to summarize it, but really thankful to the panel. It was a very feel-at-home panel, especially, when I'm hearing terms like the feminist foreign policy, SRHR, adolescents, young women. I forgot to introduce myself. I'm Smriti, and I work with the Asian Pacific Resource and Research Center for Women, ARROW. We are a regional SRHR organization based in Malaysia, and we work across Asia Pacific. While we acknowledge the need for women leadership for advancing gender equity, I feel that we also need to acknowledge that adolescents, young women, and women are not homogeneous groups. How do we ensure that women leadership asks for more intersectional issues, especially issues of indigenous women, issues of women with disabilities, and also bringing to the table contentious issues like FGMC, like abortion, which is often deprioritized to a large extent. And when women leaders are bringing these issues, when structurally excluded women leaders are bringing these issues, how, as quote unquote, experienced, seasoned women leaders, we can ensure the safety and security of these women in policy making and decision making spaces. Sorry if that was a long ask.
Yeah. Last one. Yes, you take it? Yes.
My name is Arancha Cedillo.
Yeah, please. Down.
Yes,
excellent.
Hi, my name is Arancha Cedillo. I work for the Health Diplomacy Alliance as part of the Diplomatic Task Force. And I just have a very simple question for all of you. If you could provide with one example of some of the measures that have already been taking place. So we're talking about what needs to happen to change, to increase those numbers, to work towards gender equity. And I wonder, what are the things that have already happened to live on maybe on a positive note? Thank you.
Should we take the last one? What we're doing? Yeah? Yeah. So the panel is saying is yeah. Over to you. Yeah.
I do have a short comment. Please.
Just, can you use the mic?
Hello, my name is Maxine Scringer-Wilkes. I'm on the board of the International Lactation Consultant Association. And thank you so much to this panel. I just wanted to say that we know at ILCA that World Health is transformed through breastfeeding and skilled lactation care. And this is women's work. Primarily women breastfeed. And if we're not supported to breastfeed, we are not reaching on non-communicable health diseases such as breast cancer, uterine cancer. All of those are decreased for us when we are supported to breastfeed. In addition to cardiovascular health is improved, and also risk of diabetes is down, and those are non-communicable diseases that are on the rise. And so most of us here we're here for women, and so ILCA encourages you to support skilled lactation care wherever you are. Thank you.
Thank you. So we have how we educate the room, especially senior leaders, how we integrate women leaders into those security aspects. What is the positive side of it? How we can the panel wrap up all these questions, and then we pass to the concluding remarks. And who would like to jump in?
I will be very brief. And I just one thing which I want to say to the colleagues on that side who ask, don't ask for permission. Do it.
Take it.
Power is never shared. It has to be taken. And we can talk more in terms of examples that somebody has just asked on how the partnership that I work for has actually institutionalized meaningful adolescent young persons engagement. For us today is not just an acronym. That's how we work. So I really, the only thing I would like to say, don't ask for a permission.
I will graciously pass this question to the fellow panelists because I was asked the question about meaningful intergenerational leadership. And indeed, you are very correct that there is a lot of labor that is done from our generation, but indeed, they are the ones with a lot of experience and expertise and decision-making power. So colleagues, we are waiting to hear from you for your advice.
So I nothing to add that pass the floor to Dr. Flavia Bustero, who is a member of the GW Voices and who could answer some of these questions for sure.
Thank you so much. And I want to say first how great this opportunity is that we are here in this room. I spent the earlier part of the afternoon at the World Health Assembly, a place where I used to spend a lot of years. As some of you know, I worked for the World Health Organization for a long time. And the entire room was full of men that were discussing with men and were arguing with men. And it's striking that the issues that are now being discussed within the World Health Assembly relate to issues of peace and security and conflict, and they are the vehicle of those issues are really changing. So the questions that you are asking, for some of people like me that you can say I have much more experience in this space, is a question that challenges all of us. This group that we have put together with the wonderful Honorable Helen Clark, you will hear from her in a moment. She, Susanna Marcora, and Irina Bukova were three of the candidates for the position of the Secretary General of the United Nations in 2016. And they put together this organization once they did not manage to actually become Secretary General, and they brought on board some of us. I myself tried to become a Director General of this organization, and I didn't succeed. So we do not have the answers, because we actually are a group of women that have managed many, many steps, but we actually did not manage to change the system, okay? So rooms like these are where the place of solidarity emerges. And the rooms like these are so important for the understanding that it is not an individual challenge you, Merete, are confronting, or you are confronting, or the nurse on the front line, or the midwife that is providing care. This is a system that is preventing this kind of leadership that we're asking for. We're not asking for having more. We are just asking for an equitable share of leadership. At the end of the day, in health, in the health sector, women represent more than 80% of the workforce. And as you say, they are the doctors, they are the nurses, they are the midwives, they are the chair of the Parliamentary Committee of Health in the parliaments in many, many countries of the world. So why are we not leading? Why are we not the ones that provide the space for these conversations, sometimes challenging, as you said, bringing in the intersectionality, bringing in the sexual and reproductive health and rights? So the first point I like to make is that let's not accept that this architecture and this system makes us invisible. Let us recognize ourselves and count ourselves. We are a force. We are a force, and we have a voice. And this voice can be used for changing. First point. Second point, let's not look at health and global health in isolation. We need to put this in the broader context. I'm sure Helen will come in and will talk to you as a former prime minister. Who has seen that picture of the President of the United States and the President and the Premier of China meeting? This is the power to be in the world that meet, and there is not a single woman in that room. There is not. So let's not look at it just as health. This is a broader dynamic that currently we are living in, and we need to reflect on that and confront that broader dynamic. And it's not just us working in the health sector. We need to look at where are the allies that are confronting the patriarchy, that are confronting the inequality, and that are confronting the inequities in other sectors as well. And then one thing that I think is quite important that people have asked, can something be done? Yes, there are multiple examples where when we act together, in concert, from different point of view, we can achieve. Just one small example. Last year, the Interparliamentary Union, by the way, the Interparliamentary Union is one of the organizations where the gender word is still being used and still being promoted very, very much. It's not like the World Bank where the gender specialists are now abolished and now we have the social specialists. We do not have gender specialists any longer. But the Interparliamentary Union detected that actually in the Gambia there was an attempt by some members of parliament from the opposition to ban the law that was outlawing female genital mutilation. And through the coalition that the IPU was able to mobilize, the Partnership for Maternal, Newborn and Child Health, some of the young leaders, some of the Islamic leaders, because some of the reasons why in the Gambia this practice was promoted was it's conforming to Quran. So mobilizing this coalition in a very respectful manner, as you said, Rajat, we need to engage with the leader of faith in a way where there is a place of meeting. This attempt to repeal the law was actually stopped, and so the law is still in existence in the Gambia. I'm just using this as an example because it's a small win, but it is a challenge that sometimes people can say, oh, okay, it's unsurmountable. No, it is unsurmountable. Nothing is like Nelson Mandela always used to say, nothing is possible until it is done. And that's what I like to leave with this group. Nothing is impossible until it is done. Now, here, in this organization, there is a quest for leadership that is coming up. All of you are hearing now there is a candidates for the Director General. This organization has only had 2 women leaders of the organization in its 80 years of existence. So less than a fifth of the time this organization was led by a woman. So I leave it with you. I think this is a room where there has to be a quest for having this change, this transformation of leadership in the World Health Organization, not only because it is the right things to do, but it's because the time is the right time for confronting the kind of pressure and the kind of transformation that we are seeing. I'll pass the baton for the concluding remark, the rest of the concluding remark to Helen, our founder and our leader. Please, Helen, come in.
Well, thank you, Flavia, and greetings, everyone. I'm sorry, a little bit late. There's a lot on this week, but great to hear that part of the discussion that I did hear. I mean, what's so obvious is that global health reflects global power structures generally. It's not a silo. It is what it is, and it is hard to change. It is hard to change, as Flavia said. For the Secretary-General position, the majority of candidates last time, 10 years ago, for the SG position were women. And not a single one of us really were ever in the top group of candidates who were polling in the various processes. And here we are about to go to another Secretary-General election. Will we see every woman who stands just knocked over because they're not the image of a Secretary-General to a lot of the member states? I must say, when I ran in 2016, it took me back decades in New Zealand. When I became a member of Parliament in New Zealand in 1981, women were under 9% of the membership of the Parliament. Well, these days it hovers around 50. Some governments will be a little above 50, some a little below, but it's changed enormously. In the last 29 years, New Zealand has had women leaders for 16 years. So we've cracked these ceilings. We expect to have a fair shot at the top jobs. Women have held every top statutory position in New Zealand, and generally more than once. But come to the global scene, it's different. And we really do have to break our way in. I often say that you know, if you're looking to break into these structures, you need a lot of support from women and from male allies. And as Rajat observed, we haven't got a lot of male allies in the room, but you need them. You know, my country was the first in the world where women fought for and won the right to vote. And all male parliament voted on that. You needed some allies, right, to break it down, and somehow they did it. But I often say you have to, you know, roll out the red carpet for yourself and kick the door down, but you want to know you've got a support group as you do that, so you're not just dismissed as a troublesome woman, right? You're part of a movement that wants to come forward into these positions. Listening to the comments, it is important to emphasise that not every woman's leadership will be feminist leadership. And that's why looking at woman candidates, you know, we're not going to support people, for example, who come out of the anti-rights movement, which is very active and well-funded, as we know, quite alarming. I mean, the arguments for equal, in fact, I'd argue more than equal representation for women in global health are that we are the vast majority of the workforce and we disproportionately use the services. So why shouldn't we have a disproportionate share of the power, really? That would be a fair argument. But we know that, you know, the way decisions are made around health, women's health conditions are much less researched than men's. There's quite a lot of evidence compiled around that. And so often, as has been referred to, women just aren't consulted, whether they're old or young or middle-aged or whatever. I recall when we did the consultations for the independent panel on pandemic preparedness and response, so we spoke with midwives, dedicated consultation with nurses, to a person. They said, we were never consulted. There are all these structures around how to handle COVID, and here were these women on the front line, never consulted by their national, you know, pandemic authorities or whatever. Now, Rajat may have made this point when he spoke, but one of the issues which is concerning us at the Partnership for Maternal, Newborn and Child Health is there's a lot of debate about the global health architecture now. And all this debate is about what the structure should be. Shouldn't we start with people? And shouldn't we start with, you know, predominant users of the system, women, their children, adolescents? But that's not where the discussion centres. It's sort of, you know, structures and diagrams, put this together, put that together. We could lose a focus on things that really matter to women, and we have to get the need to protect and promote all the systems that work for women as we discuss these architectural reforms. At the Global Women Leaders Network, we're taking a particular interest in the proposals around the UN Population Fund and UN Women. You know, the UN Population Fund is not a gender entity. The UN Women is, and primarily focused on women and girls. But the UN Population Fund has a section on reproductive health and rights mandate, which comes out of Cairo in 1994. It does, you know, tremendous work in that area. Now, if you crunch them together, and then they go to the General Assembly for a new mandate, what sort of mandate do we think they're going to get at this time? So, you know, we really need to watch these architectural discussions to see what may well be lost. So I think there's a lot of issues here, and of course, you know, institutions that have never shared power with young people or with women, as Rajat said, they're not going to just give it up. We have to fight for it. We have to fight for it, and I know it's hard, believe me. People talk about glass ceilings. A marvellous woman who set up the Council of World Women Leaders, Laura in DC, once said at a meeting, she said, it's not a glass ceiling. She said, it's just a thick layer of men. So, you know, And that's what you take your crowbar to. We have to fight for it, and we have to change these institutions because, most of them are never ready for us, but we have to fight our way in. But we can't do it alone. We can only do it through networks, alliances, peer support, intergenerational support as well. Some of us have got the battle scars and can share a little experience. We exist as an organisation because at GWL we want to see younger women come up through, and in much greater numbers than we came up through, and we want to grow the base and make it possible to change these systems and structures. So I'm really happy that we've been able to provide a platform for this discussion. We started this last year, and this is an immensely bigger group. Next we need an auditorium. And more voices, young, middle, old, but this is a very important cause, and if we don't get more feminist women into leadership, we can't be surprised that we don't get the policies and the directions that we want and need. So we have to create space for all these voices and fight for it. Thank you.
I have nothing else to say. It's just to thank the panelists, thank all of you for being here, all your questions, to the organizers, GW Voices, for once again doing it together with the partnership of all the other organizations, the Government of Spain, University of United Nations, PMCH, and all of you for being here with us. Just take the reflections of what the panelists have said. Use it. Like Raya said, don't ask permission. Just do it and make the best of this week. And put women, feminist women there in all your process of negotiations in all your meetings. That is part of the conversation. Thank you very much. Thank you.